you're not able to make any progress, then what should be done? What are your options? How to take it to a conclusion without causing a complication? So remember, first, do no harm. If you are unable to complete the surgery safely, consider your options, reevaluate your options. Stop the surgery when the dissection is too difficult and you are unable to progress satisfactorily. If you are unable to identify the hepatocystic triangle, if you are unable to achieve the critical view of the safety, you find that there is already some bleeding which continues to happen. The moment you start dissection, because of extensive fibrosis, everything is frozen. Keep your ego aside, stop the surgery, and reconsider your strategies. Consider what options do you have now. And you can go ahead and choose from any of these 5 bailout options now. I'm going to talk about them briefly one or the other. The first option which you can consider is to change your approach and start doing that from top to bottom. So if you are unable to dissect safely in the area of the hepatocystic triangle, go the fundus first, or as we call it, the retrograde laparoscopic cholecystectomy. Now this starts at the fundus of the gallbladder and we keep dissecting downwards till we reach the two ductal structures. We have separated the gallbladder from the cystic bed. So if I take this video, so you see there were already some omental adhesions which were separated from the gallbladder. So once you see this gallbladder here, now we start separating it from the gallbladder, the liver bed, from the cystic plate, and we start coming from above downwards. There, you see that the gallbladder is being separated from the undersurface of the liver. The dissection is being done on the cystic plate. This has to be done very careful. And you must remember not to keep dissecting too far. If you go too far, again, the risk of having a eye or a injury or a vascular injury. So this approach actually helps you open the angle between the cystic duct and the bile duct and contributes to lesser bile duct injuries, and you can actually avoid a conversion to open surgery. So see, once we have separated the entire gallbladder from the bed, you can clearly identify two and only two ductal structures. So this is a top to bottom approach, a fundus first or a retrograde lap cholecystectomy. This is one of your bailout strategies. The next thing which you can consider is doing a subtotal cholecystectomy. And this is again done in two ways. One is the fenestrating subtotal cholecystectomy, and the other is what we call as the reconstituting here. This was suggested way back in 1955 as a replacement for doing a cholecystostomy in open cases. So the idea here is that we are going to remove the part of the gallbladder which we can dissect out safely. And this is usually done again when the dissection of the callus triangles is difficult and we are unable to achieve the critical view of the safety. So two different approaches, as I told you. The gallbladder is not fully removed in both of these cases. The diagrams will help you understand the difference between the two. Here, we are going to remove the anterior wall, most of the gallbladder, and leave the difficult part of the dissection. The posterior wall of the gallbladder remains adherent to the cystic plate, but you are going to make sure and ablate this mucosa thoroughly. Then many surgeons, we try to close the cystic duct orifice here and simply leave this open here like this. The problem here is you can have a lot of bile leak in the postoperative period. The other approach is reconstitution, where you remove the part of the gallbladder which you can do safely, and then you close the remaining part of the gallbladder. So the chances of post-operative bile leakage are less, but as you can see and understand from here, now that you have left a part of the gallbladder behind, there is a possibility of always developing a recurrent CBD stones or recurrent gallstones here within this remaining part of the gallbladder. So, but these are two bailout options which are really helpful. The third is you leave a tube, a catheter, a wide bore catheter in the gallbladder. Do a tube cholecystostomy and come out. So once you open the gallbladder, you move all the stones, leave a tube, close the gallbladder over a tube, and take this tube out from the abdominal wall. Now this decompresses the gallbladder, removes the stones, and it gives you a window period You can again go in after 2 or 3 months when things have cooled down and then do your complete cholecystectomy. Another bailout option is to simply convert from your laparoscopic to open approach. Now, conversion to open approach is actually a very sound surgical judgment. It should not be considered as a failure. It should be viewed as a decision which is made in the patient's best interest, and it should not be considered as a failure on the part of the surgeon, because the primary objective is to have a patient who is safe, hale and hearty at the end of a surgical procedure. So surgeon must be wise enough to recognize the point of no progress. You are trying to operate, but you're not achieving a critical view of safety. So know your limitations, because the best surgeon is not the one who never converts, but the best surgeon is the one who knows exactly when to convert. So this is again a very reliable bailout option if you are coming across a very difficult dissection. Lastly, do not forget this importance of asking for help, calling in a colleague who can, give you a second opinion. And if both of you find that, okay, this is not a case which can be handled here, it is better to close, come out, and refer that patient to a higher center where they're dealing with such kind of cases. This is again a very sound and a wise decision on the part of the operating surgeon. So I'd like to wind up my talk now by giving you these take-home messages. While doing a laparoscopic cholecystectomy, the common bile duct should never be intentionally exposed. That is not our area of interest. Do not rely solely on the infundibular view. Rather, do a proper dissection of the hepatocystic triangle and achieve the full critical view of safety in every before any duct structures. Remember to use the Rouvier circle and the segment 4 line as important anatomical landmarks. And in spite of all your best attempts, if the anatomy remains unclear, stop and think and consider, choose one of those 5 bailout strategies rather than causing a major complications.